Hello, everyone, and welcome to our Monday Night IBD Brunch series with the expert. We're going to be discussing the unmet needs in IBD and new approaches to IBD care. Today, I have the pleasure to be joined by two fabulous colleagues to talk about how we can advance health equity in IBD in the LGBTQ plus community and in the African-American community. This series is supported by educational grants from Abbvie, Janssen, and Takeda. And before we start, please take a moment to answer the pre-polls linked below or by using the QR code shown on screen and let us know who you are. This is a CME certified program. The tweets below also include details regarding how to obtain your CME credits. I'm Dr. Ali Sharabadi. I'm the founder of Monday Night IBD. I'm an associate professor of medicine at Johns Hopkins School of Medicine and the clinical director of the IBD Center at Sibley Memorial Hospital, part of the Johns Hopkins School of Medicine network. I'm today joined by Dr. Aja McCutchen. She's partner and physician executive at Atlanta Gastroenterology Associates, a division of United Digestive in Atlanta, Georgia. Aja, welcome.
Thank you so much, Aileen. Thanks for having me today.
I'm always excited to talk with you. I always learn something every time we have a discussion about GI care and how to advance health equity in our communities. I'm also joined today by Dr. Victor Chedid. He's an assistant professor of medicine at Mayo Clinic, Rochester in Minnesota, and of course, a Lebanese compatriot. Victor, welcome today.
Thank you so much, Aline, and I'm so excited to be here as well, and thanks for inviting me.
I'm absolutely excited to have you. You have done fantastic work, and we're going to be talking about this in a bit. Our disclosures are shown on our screen. Victor, I'm going to start with you. You have established a fabulous clinic, definitely answering an unmet need. You are the director of the IBD Pride Clinic at Mayo Clinic that focuses on the needs of patients with IBD who identify as LGBTQIA+. So my first question to you is help us recognize the correct terminology when we are identifying the LGBTQ community. I have read LGBTQ+, I have read sexual gender minorities. Guide us and walk us through the correct terminology.
Yeah, thank you, Aline. That's a great place to start because everybody sees these letters and it is important to understand what these letters represent. LGBTQIA+ is an acronym that stands for the community that identifies as sexual and gender minorities. So you will see these terms used interchangeably, and that is somebody who is not heterosexual, cisgender individual. So anybody who identifies as not heterosexual, cisgender belongs to the sexual and gender minorities or the LGBTQIA+ community. And if I were to go through what each letter represents, it is lesbian, gay, bisexual, transgender, queer, and plus represents the fact that the gender identities, sexual orientations live on a spectrum. So people can have a wide spectrum of gender identities, sexual orientations, and can belong to this array of identities. That's why they put the plus to be all-inclusive. And not miss anybody who belongs to that identity. And the other thing that's important to recognize is the difference between sexual orientation, gender identity, sexual expression, and sex assigned at birth. These are different terms used to define different things. So sexual orientation is defined by an individual's sexual and emotional attraction to a certain sex or certain gender, including somebody who is heterosexual or homosexual or asexual or pansexual or bisexual, so on and so forth. The other term is gender identity, and that's very different from sexual orientation because gender identity is how a person perceives their gender. So it's a person's experience. And it is a social construct rather than a biological one. And it is different than sex assigned at birth. which is usually determined by our chromosomes that we are born with. So sex assigned at birth usually can be XX, XY, and that defines male or female or intersex. But then the gender identity is a social construct and not a biological one, and can be different from the sex assigned at birth. And if somebody's gender identity and sex assigned at birth are aligned, this is what we call a cisgender individual. And if the gender identity and sex assigned at birth are not aligned, then that's somebody who's either transgender or gender fluid or gender nonconforming. And lastly, there's gender expression, and it is how somebody presents themselves in the world. And that's, again, usually somebody might have some feminine characteristics, some masculine characteristics, some androgynous characteristics, and gender expression should not define or make us as physicians make assumptions about somebody's sexual orientation or gender identity just by how they are expressing themselves.
Victor, I'm going to stay with you. Can you tell us what we know about IBD in the LGBTQ community in terms of incidence, phenotype, but mainly what are the gaps in knowledge? Because I have to admit, I have read very little data on how IBD affect this community. So can you tell us what are the gaps in knowledge that needs to be addressed in this particular community living with IBD?
The knowledge that we have is very limited because there hasn't been a lot of studies that have looked at IBD specifically in the sexual and gender minority community or sexual and gender minority individuals. So we don't know much in terms of natural history of disease, or if there's any difference in epidemiology in sexual gender minorities and cisgender heterosexual individuals. But we assume the disease is the same and it affects everybody the same way. And the predisposition of getting the disease should be very similar. But there are specific considerations to look at in the sexual gender minorities that might not apply for somebody who is from the cisgender heterosexual community. Pertinent topics that could impact the sexual gender minorities in IBD are related to folks who belong to the transgender community, for example. We don't know much about the impact of gender-affirming care on IBD. But we definitely recognize that gender-affirming care is life-saving to folks who are transgender or gender non-conforming, and it is an important part of their daily living to have a gender-affirming therapies and gender-affirming care. And therefore, we need to evaluate how gender-affirming care might be impacting IBD and how we might focus on managing the IBD differently, or recognizing what impact estrogen might have on IBD or testosterone might have on IBD, or if somebody is getting gender affirming surgery in their pelvis, for example, how that might impact their Crohn's disease. These are very important topics that we need to understand better so that when we are seeing our patients in clinic, we are better counseling them regarding their IBD and their gender-affirming care, and different ways that we can manage IBD that might be pertinent to that specific community. Other things that to keep in mind is, for example, when somebody is engaging in anal receptive intercourse and has perianal Crohn's disease, for example, we don't know much on how to counsel them, or many folks might come to us talking about the fact that they cannot engage in anal receptive intercourse. So we need to be better equipped in talking about sexual health and sexual practices as IBD providers, because our patients are going to seek us to have these discussions. Or let's say somebody had a total proctocolectomy and has a pouch. Again, they might come to us to ask us about engaging in safe anal receptive intercourse. And there are the topics are endless that we need to understand better in that community, and I can talk about it for hours. But these are a few things that come right up to mind when you ask me that question.
That's perfect, Victor. I think what you're highlighting is that for us as physician and clinician, we need to be comfortable asking the right questions for patient and approaching maybe topics that are deemed sensitive we do need to be comfortable addressing these topics because patients might not be comfortable bringing them to us, but also we need to have the right knowledge to inform our patients. Eja, I'm going to turn to you. You have done amazing work to advance health equity in the GI community. You were the DI chair for the Digestive Health Physician Association, which include more than 100 prior practice. And you're recently recognized by the Crohn's and Colitis Foundation as the Physician of the Year for your advocacy work to address health inequity in the GI and IBD space. So my question to you is a little bit similar to what I just asked Victoria, is to, in your perspective and the work that you have done and what you see in your community and in your advocacy work, where do you see the knowledge gap in terms of IBD in the African American community? Where do you see the health inequity in terms of access to care, access to the right therapies, access to IBD specialists, education in terms of understanding what IBD is in the minoritized communities like the African American community?
Disparities in IBD care propagate at every touch point. And, if we just take a step back and look at the rising incidence of inflammatory bowel disease, there's been a 39% increase between 1970 and 2010 in white Americans. But in Black and Latinx communities, we've seen a 134% increase in inflammatory bowel disease. And if you ask myself, you, Dr. Charabati, you, Dr. Chedid, why this is, we can't really fully explain it, right? We think that this may boil down to increases in ultra-processed foods, for example, access to care, other social determinants of health. But when we look at our database and our studies that we derive significant conclusions on, we're an evidence-based field, and everything that we do is supposed to be evidence-based. Yet Black patients accounted for only 1% in 200 outcomes-based IBD studies, right? And then if we look at our current clinical trials, 60% of the population is going to be non-Hispanic whites, and then Blacks and Hispanics are going to be 32%, but the clinical trials, 90% are white. Even in our newer therapies, I was so excited to see what the representation was now that we're really pushing for diversity in clinical trials. And with our small molecules, we're still at less than 3%. And these are therapies that could potentially be life-saving because we can give samples in the office, because we don't have transportation with those oral therapies as a barrier. So I want to look at things on the bright side and say that we are acutely aware that there's a lot of work to be done at a grassroots level and certainly from a systemic level to help to fill some of those knowledge gaps. But it's a loaded question as to where we start, because we have a lot of internal work to do, and then there's external work that needs to be done here too. And so, I think what's really nice is that we have organizations that raise awareness. We have organizational leaders such as those from ABGH that are helping to provide some framework whereby we can really understand and systemically approach this multi-targeted approach in a systematic way. So there is some guidance that's being provided as to how do we implement change from a provider or practitioner level. How do we help our practitioners to understand some of the biases that may come into play when they're treating patients? And then how do we, as sort of a community, how do we address some of those community challenges all the way up to the policy level? How do we implement changes in policies such as the STEP Act? We know that there are persistent disparities in access to therapies, and there are going to be certain groups that are also disproportionately affected by that access issue. So there's so much work to be done. I think, again, that's a loaded question, but we need to start at the grassroots level. And probably we need to start with just trust, building relationships, and then understanding what some of those systemic and structural barriers are.
This was fabulous. I mean, for a loaded question you touch upon all the important points, and including starting with our own bias, right? Whether it's toward the LGBTQ community, whether it's toward minoritized population, Blacks, Hispanic, Middle Eastern, and Southeast Asians, anything that doesn't look like us, right? And so I think first is getting that in check and really working with our community, our hospital system, our private practice system, our institution system, and all the way to health policies. And I agree with you. Our patient with IBD face so many barriers. And when you add the bias, when you add the lack of knowledge, or maybe when you add physician or clinician feeling uncomfortable because they just don't know enough about a topic, that adds more layers and we kind of dumping it on the patient to figure the system out. And I was even thinking there's so many intersectionality there, and I cannot imagine being part of the LGBTQ community and African American and maybe other normal life that actually end up being working against you because of the system. So how you touch upon the clinical trials, and I agree with you that our clinical trials are mostly whites. It's hard to tell our patients who are non-white whether or not this drug would work for them because they are underrepresented. Ija, I know there have been such distrust of the medical system from the African American community because of previous abuse in terms of how research used to be conducted without proper ethical oversight. How can we encourage our African American patients to, in terms of being part of the clinical trial or understanding what research is, or being on therapies that they are concerned about because of potential side effects or, everything that a patient would be worried about in terms of therapy, but particularly in that community where there has been more distrust maybe about the medical system?
Yeah. Well, first, thank you for acknowledging that, we've had an issue historically with trust that has a very good reason behind it. Since the 1930s, we've kind of been in trouble, right? That's where the whole Tuskegee Project started, which really wasn't that long ago. And then we've also had redlining that started to take place at that time. And that has had a very negative and pervasive downstream effect on the health outcomes of those that are in Black and Brown communities. I think Melody Narain Blackwell actually said it very well in terms of how we start to knock down these barriers. And it starts with our language. We need to have language that is culturally and linguistically inviting. So one of the things that really resonated with me, I listened to the AGA Diversity and IBD clinical trial series, and what she said was that we need to think about just using terms such as clinical trials. What does that mean? Are you doing another experiment on me? Is this a trial and error situation here? And we need to change that language to language that is more inviting, such as clinical research opportunities. Because, what we know is that strengthening that community web is very important for the African American community. For example, the way that we receive information oftentimes is from our peers. This is why complementary medicine played such a big role in African American communities, because we hear that, this particular supplement, which is natural and not synthetic, had a positive outcome on, our auntie's, illness. And Black and African American communities, there are 3 times increased risk of complementary alternative medicines, which includes prayer when you're dealing with chronic illness. So I think we have to change the way that we're approaching these conversations and use language that, as she said, that your language can either be an invitation or a disqualification. So it's either going to be inviting or you're going to run the other way. So I think that's the first step. The second step is, ideally, we want to improve representation, right? But that takes time. It is probably at this point where we are right now today, it is unrealistic to think that every Black patient, for example, is going to have provider concordance. We know that that makes a big difference from a racial, ethnic, language standpoint. That is desirable, but that's not where we are right now. And even in certain communities, we may not ever be able to achieve, that exact concordance. And I think that's okay. But building trust early is going to be critical here. And how does that start? That starts by really transparency and vulnerability. The way that the patients open up to us, this is challenging, but we also have to open up ourselves to receive that particular information. And then as soon as a patient hits the door, it's kind of like you need to get to know that particular person. And it's not like, do you have transportation? Do you have this? It's like, what does your situation look like? If they come in a uniform, for example, I'm asking, where do you work? What are your hours like? Do you have kids? And so you really need to pick up on those visual cues. And then early on, introduce the concept of, we have a lot of therapies already available, but we also have clinical trials that are going to be available. And so you kind of plant that seed very early on in the conversation. And as you build trust and rapport, it's not like, oh, all of these therapies are not working for you. Let's throw you into a clinical trial. You've already planted a nice seed. And so it's a much more inviting conversation to say, you know what, these therapies failed you. But remember when I talked to you about these trials that we have available, I think it may be time for you to move on into a clinical trial.
Victor, I want to bring it back to you. What can we do to maintain patient confidentiality when conducting research in gender minorities with IBD? And what can be done to encourage our research partner to look into all the unanswered questions as it relates to IBD in this community?
Many people are at different stages of their coming out, per se, if I put it between quotation, because sometimes you are somebody who is maybe out only to your friends, and your doctor is the next person who you're out to about being gay or starting to think about yourself being transgender, and your doctor is the first person you are sharing this with. So that's a very sensitive thing, and that patient might have felt very comfortable with you and shared this in secrecy with you so that you can help them. And so at the end of the day, that trust can be broken very easily if the data is breached or the medical records are breached. And so when we want to enroll patients in clinical trials and obtain sexual orientation, gender identity into the clinical trials, we have to be very careful when we're documenting it. Are we getting the patient's consent and the patient's approval of documenting their sexual orientation, gender identity? How are we protecting their data, and how are we dealing with that data? Will that data be provided to the pharma company, to industry, or will it be provided to anywhere external to the medical system you're in, or to the medical record? And so all these securities have to be in place, and regulations have to be in place so that you can make sure that that patient who is willingly enrolling in the clinical trial and willingly sharing with you their sexual orientation or gender identity, and they're giving you their consent to share that information in the clinical trial, that we are protecting them.
So before we conclude, and since this is a social media platform, my last question to you is, how do you see the role of social media in advancing IBD knowledge and our approach to IBD care, and encouraging everybody to be part of the change in terms of advancing health equity? So, Edja, you want to start?
I think that social media is a huge opportunity for us to connect people, communities, industry, and change policy. And, one of the things with social media is people can't hide like they used to, right? And so when there is a negative experience, it is amplified, it is catastrophized sometimes. Is that all negative? No, because I think there is going to be a greater emphasis on accountability, making sure that patients are satisfied with their experience within the traditional system. But I think one of the things with healthcare inequities, specifically in our communities, are partnerships. And one of the I guess the silver lining of all of this is that through social media platforms, partnerships are so much more organic, and it's easier to reach people and sort of decentralize. For example, we can decentralize clinical trials now just using social media. So now, when we think about IBD research, we used to have to think about, okay, what is the exact reach of the study? How will we access people? But now with social media, you can really access people across the nation. You can use, Zoom platforms such as this to potentially have touch points and recruit those that may have had transportation issues or otherwise not been a part of this. So it really allows collaboration, cross-pollination of ideas. You can foster better partnerships. You get that real sort of unity that you need to close these gaps and improve diversity and in our clinical trials and our data that we have that we use to make decisions. So I really think that social media is very powerful. And I think it has its advantages and disadvantages, but we need to really take advantage of the fact that patients are on there. And we have an opportunity to intervene on some of these misconceptions, right? We have platforms such as this that say, okay, hey, here's the data, and we simplify that data and communicate that across various communities. And I think it's very powerful.
The advocacy part of it is so important, because when you are somebody who is being counseled that you're going to need a colostomy or an ileostomy, and this is the first time you hear it, you think you're the only person in the world, but then you go on social media and you see this model or this Instagram influencer who's living their life with an ostomy, and they're living their best life with that ostomy. You would relate. You would feel that I see somebody like me. I see somebody who is going through similar things, and I feel that gives some reassurance, some normalizing of these difficult situations and difficult topics for a patient and for an individual who is suffering on their own. So there are so many pluses to it, and we got to be very careful of the negatives, but I believe there are so many pluses out there from social media. And Monday Night IBD is a prime example of that, to be honest.
I appreciate that, Victoria. That's very kind of you, and it's bringing people together to have these kind of conversation, learning from each other, sharing the expertise, and also having the patient voice to understand their unmet need, and also having like you were saying, Eja, that like patients and physician and industry and societies are there, and so these conversations can happen in a healthy way and in an inclusive way, and that is the way to move things forward. So thank you both. Thank you, Dr. McCutchen. Thank you, Dr. Chedid, for being here with me today. That was a fantastic conversation. Before you go, please make sure to answer the post-polling questions under the video, and don't forget to claim your CME credit using the links below the video or the QR code shown on the screen. Thank you again, everyone, for joining, and thank you both.